Well, good morning, good afternoon, and good evening to everybody. I'm so delighted you could join us today for this exciting conversation about primary healthcare measurement for improvement in the Eastern Mediterranean region. I'm Beth Tritter. I'm Executive Director of the Primary Healthcare Performance Initiative, or PHCPI, and we are delighted to co-host this session with the WHO Eastern Mediterranean Regional Office. PHCPI was established in 2015 and is a partnership of the Bill and Melinda Gates Foundation, the World Health Organization, the World Bank, UNICEF, Ariadne Labs, and Results for Development. And our partnership was created to help catalyze transformations in primary healthcare systems, beginning with better measurement. Over time, we've developed a set of tools and approaches to help countries understand the strengths and challenges in their primary healthcare systems and prioritize key improvements. The Vital Signs Profile, our flagship assessment tool, was launched in Astana at the Global Conference on Primary Healthcare in 2018. And it combines quantitative and qualitative information to provide countries with a snapshot of their primary healthcare systems with an eye toward improvement. PHCPI has worked with countries in every region of the world to help prepare these assessments and to use them to drive strategic policymaking and investment. And since 2019, we've been very fortunate to partner with WHO's EMRO region on the Primary Healthcare Measurement and Improvement Initiative, or PHCMI, which you'll hear a little bit more about in a moment. Working hand in hand with Dr. Hassan Salah, WHO EMRO's Regional Advisor for Primary and Community Care, and Ms. Hagar Azab, WHO EMRO's Regional Focal Point for PHCMI, and their team. We've worked to integrate PHCPI's assessment approach into the unique approach that EMRO has developed for the region. And we've been very pleased to collaborate with several countries in the region as they have developed their primary healthcare assessments. At this critical moment, when several countries have completed the assessment phase of PHCMI and are moving to use that assessment to drive improvement, I'm really excited that we have representatives here today from Oman, Morocco, Libya, and Pakistan to share their experiences with PHCMI, including development of the Vital Signs Profile. As we begin to emerge from the COVID-19 pandemic, we've seen clearly how primary healthcare systems have played a pivotal role and have been stretched thin by the requirements of pandemic response and recovery, while struggling to deliver the routine and essential health services that people need every day in times of crisis and calm. As we look toward the future and look to build primary healthcare systems that are strong enough to withstand shocks while continuing to meet people's health needs at every age and every stage of life, we look forward to hearing how these 4 countries will use the assessments they recently completed to guide their work. Before I turn it over to Dr. Hassan and Hagar, a few housekeeping notes. So first of all, Q&A. Attendees are encouraged to ask questions. We welcome questions, and we'll have some time for questions toward the end of the session after the presentations. If you can specify for which panelist your question is, that would be fantastic. In the live Q&A function that's in the Health Systems Global portal throughout the event, and we'll make sure that the panelists see the questions. If you have a comment or observation that's not a question, please feel free to use the discussion forum feature that's also attached to the platform. Just so you know, the webinar will be recorded and it will be available on demand for later viewing for those of you who might need to leave halfway through. So first up, I am very pleased to welcome my colleague, Dr. Hassan Salah, WHO's Regional Advisor for Primary and Community Care for the Eastern Mediterranean region. Dr. Hassan?
Thank you, Beth. Thank you very much. Can you hear me? Hello?
Yes, we can hear you.
Excellent, excellent. Thank you very much. Good morning and good afternoon, everyone. The focus of the attention to the health system response in the first wave of the COVID-19 pandemic emphasized the hospital setting with less awareness of the key role played by primary health care. We reached to almost 20,000 physicians in our region are undertaking WHO EMRO online course for the role of primary health care in the context of the COVID-19. And our target is to reach to almost around 100,000 over the coming couple of months. Today, primary healthcare played an important role in the infection prevention, early detection, management of the mild COVID-19 cases, and maintaining the essential health services. Since the role of the primary health care was endorsed in Astana Declaration and the high-level meeting on the universal health coverage, there has been increasing attention on the assessment and the improvement of the primary health care services on global, regional, and the national levels. Over the last 2 years, and to fulfill our commitments made for the 2018 Astana Declaration, the WHO established Primary Healthcare Measurement and Improvement Initiative in collaboration with Bill and Melinda Gates Foundation, UNICEF, WONCA, and our colleagues from the PHCPI, with the objective of identifying the gaps in the primary healthcare service delivery in 20 countries in our region. This year, we completed actually the measurement phase for a number of countries and started to move towards the improvement phase. Last week, in the PHC for USC mission to Pakistan with our partners from UNICEF, UNFPA, UNAIDS, Gavi, World Bank, Global Fund, and global financing facilities, we signed a joint statement to start working on the improvement phase of the PHC-MI initiative. Similar missions will follow during this coming second quarter to Sudan and Afghanistan. I would like to introduce our colleague, Ms. Hagar Azab, EMRO focal person for the PHC-MI, for her brief on the initiative. Over to you, Hagar. Thank you, colleagues. Thank you very much.
Thank you very much, Dr. Hassan. So good morning, good afternoon, everyone. As Dr. Hassan introduced, I'm Hagar Azab, and I'm the regional focal point for the Primary Healthcare Measurement and Improvement Initiative. And I just wanted to share a few slides to give some background on the initiative itself. So I hope that you can see that. So PHCMI is, sorry, PHCMI is a regional initiative that provides the tools that policymakers, development partners, and advocates can use to assess primary healthcare services in countries in order to identify the challenges and the gaps, as well as guiding performance improvement strategies and plans. So as Dr. Hassan mentioned, there are a number of countries who completed their profiles and completed the assessment phase in 2020. And are now using the information gained from those profiles to inform both regional and national primary healthcare improvement plans. And as both Beth and Dr. Hassan mentioned, it is a partnership between Bill and Melinda Gates, UNICEF, WONCA, the Primary Healthcare Performance Initiative, Ariadne Labs, and Results for Development, as well as an interdepartmental collaboration within WHO EMRO itself. So I just wanted to give a brief timeline of what's been done so far. The initiative was announced on World Health Day in April 2019 by our regional director, Dr. Ahmed Al-Mandari. And we began with 3 pilot countries who at the time were Egypt, Jordan, and Pakistan, who were invited to participate. By July of 2019, PHCMI was introduced to all of the EMRO member states, and 20 countries were successfully recruited to participate. By September of 2019, the pilot countries had produced their draft profiles, which they hadn't completed the assessment phase, but they had begun to gather data, and implementation training and data collection began for the remaining 17 countries. Due to the COVID pandemic, there were many planned missions and in-person workshops to support countries that were unfortunately postponed, and we had to shift to a virtual platform during the assessment phase, which posed many issues, as you can imagine. But despite all of that, there were 6 countries who did complete the assessment, as we mentioned, and 4 of them were able to publish their profiles in December of 2019. In parallel to all of that, we're continuing the assessment with the remaining countries, with 4 more scheduled to publish very soon, and the rest in the data collection and assessment phase. Of course, during COVID-19, as Dr. Hassan mentioned, the pandemic posed new challenges during 2020, both on primary healthcare as a system, as well as PHCMI as an initiative for implementation. PHC quickly became part of the emergency response to the pandemic and was proven to globally be one of the key facets in COVID-19 case management. Countries quickly became overwhelmed with the prevention, detection, and management of the cases at the primary care level. And because of the redistribution of health professionals to focus their efforts on COVID-19, it caused a shift in priorities. What this meant for the initiative is that because many of our focal points at the national level who are working on the initiative were involved on the ground and in COVID response, it meant that the assessment was delayed for many of the countries and we had to pause efforts on the PHCMI implementation. However, this did provide an opportunity for us to learn from the challenges that countries were facing, as well as the response, which has provided us with insight on how an assessment of PHC needs to be reshaped in the near future. And despite everything, and as you'll probably hear in our the presentations of our guest speakers today, the PHCMI country teams overcame many obstacles and were able to provide us with the PHC country profile, as well as the vital signs profile, which is a product of PHCPI in collaboration with PHCMI. And moving forward, the insight that we've gained from both of these profiles will be used to inform regional and national improvement strategies. And with that said, I'd like to introduce to you our guest speakers for today, whose respective countries have either already completed the assessment and the profiles or at the very last stages of doing so. We have with us Dr. Badriya Al-Rashidi, Dr. Anis Lakhal, Dr. Ghassan Karim, and Dr. Sabine Afzal, who have been integral in the implementation of PHCMI, and their support has been key in both the assessment as well as moving forward with all of the gaps and challenges and information that we've learned so far. And with that said, I'd like to first introduce our first speaker, Dr. Badriya, who's the Director of Supporting Primary Healthcare Services at the Directorate General of Primary Healthcare in the Ministry of Health of Oman, and who is also the PHCMI focal point in Oman. Dr. Badriya.
Good morning or good afternoon. Thank you very much, Dr. Hajar, for the introduction. And thank you also for involving Oman in this important study. And I'd like to share with you my experience, Oman experience on conducting this study. First slide, please. As you know, Oman is located at the most southeast region of Arabian Peninsula. We have a population of 4,600,000. Many of our population are young. 37% are younger than 15 years, and we have 44% of our population are non-Omanis. If we speak about some important data, we have life expectancy in Oman has raised since 1970. Now, as per the statistics of 2018, because we collected the data for this study at 2019, therefore you'll see most of my slides on data of 2018. Our life expectancy in Oman is 76.9 a year. And we have under 5 mortality rate is 11, and infant mortality rate is 8.5. We have a problem of consanguinity, and therefore we were not able to reduce the infant mortality here since many years. And we are conducting a screening program at the primary healthcare level to tackle this problem. Next slide, please. Next slide, please, Hajar. Next slide. Yes, thank you very much. We have very strong primary health care, and we have in each administratively, we are divided into 11 regions. In each region, there is a regional or tertiary hospital with a few secondary extended health centers and many health centers which is very close to the community. If you look into our health centers or primary healthcare institute, whether it is a health center or extended health center, which we call it polyclinic, which has other services, subspecialized services like dermatology, ENT, ophthalmology. They look alike, but the size of them differ according to the number of population. Next slide, please. This is a beautiful slide. This is a beautiful slide when you see the distribution of health institutes throughout the country. So the green ones are the health centers, and the red ones are the local or wilayat hospital, which is a small hospital. It has maternity beds, and we admit in it simple cases like ARI, simple pneumonia, and rehydration. And this is the distribution. And when you go and see the distribution of people in Oman, you will see the population are also distributed equally to these health institutes. Next slide, please. So whatever the size and the location of primary health care in Oman, all of them provide essential services like general practitioner services, expanded program of immunization, MCH program, which including antenatal, postnatal, and birth spacing, as well as infertility. We have also a lot of screening program for elderly, screening program, school health screening program. We have program to screen for congenital blood disorder, and of course we have added new programs like we have added autism screening last year for children below 18 months. We have also in each primary healthcare institute we have dental services, and in some primary healthcare we have specialized clinic like diabetic clinic, hypertension clinic, and asthma clinic, and family and community doctors are conducting this clinic, and they are seeing all the patients. In addition to that, we have basic laboratory radiology services as well as community nursing services. We are trying to do this with the minimal cost for the country, because you know Oman has very difficult demographic area. We have mountains, we have seas, and we have very rough area. Next slide, please. This is an example how important primary healthcare in Oman. In the year 2018, we had 15 million visits in the Ministry of Health Institutes, 13.2 million visits, which come around 90%. It is a primary healthcare visits, and few 2.1 million visits are carried only at the tertiary and secondary. And by the way, secondary healthcare in Oman is also belonging to primary healthcare. The secondary, we mean the extended health centers with specialized clinic. And why we did this? Because in Oman, we consider primary healthcare is a gatekeeper, and it is the first contact between patient and or anybody who is looking for medical service. It is the first contact between him and the medical services, and people they don't like even to go to hospitals unless it is a very big emergencies, or they know that they are going for admission, for example, or surgery. Next slide, please. Yeah, so here I'm going to share with you our experience at the PHCMI. The process: first, we built up our team. We agreed on the responsibilities and definitions, because we have to define what is what area we are going to collect the data. So we have chosen, for example, a capital area and a remote area, so we can compare the differences and the distribution and the availability of the services. We did sampling and timeline. Then we review the primary healthcare progression module and the key definition. We identify our data source, and so we know from where we are going to get the data. We did the data collection plan, and then we started the data collection. We did the synthesizes of the data, and with WHO frequent virtual meeting. Then we conducted an internal scoring between us, and after that we send it for the validation. For the progression module, we have divided the 33 measures. We have divided them into three groups, each one 10 measures, and the last one 13 measures. We started each measure doing it from A to Z and finish it and send it to WHO, and then we start on the next 10, and at the last one we did the 13 measures. So we want to make sure that each measure we are submitting, it has complete data and complete document also. Majority of our data, we have taken only the officially published data, and for few indicators which we could not find any official published data, we choose an alternative, and it is from the departments or the end user themselves. Next slide, please. But there are challenges, as Dr. Hassan has said, Dr. Hajar has mentioned. We face some challenges, and the most challenges is that the resources are distributed in many sectors. It is not only with Ministry of Health. There are other non-Ministry of Health health sector. There is other governmental sectors. There are many professional bodies, educational bodies, public and private sector also. And it took from us some time to organize the data. Even we have the data, but we have to put it in the format that WHO they want and at the model. So this took some time. And also the actually, we have found that the data are, some of them, they don't actually measure the actual service and the actual programs, but though we try to gather whatever the WHO needs from information. Next slide, please. The strengths, we have found many strengths, like we make sure that the primary healthcare, and this is a fact, is the first contact and the gatekeeper for all services in Oman. We have a very strong commitment from staff who are working at primary healthcare. We have very good universal health coverage applicable in Oman in form of availability, because the primary healthcare is very near to the people. It is accessible not only from distance, but from language, and from it is free of payment for the Omanis and for the non-Omanis who are working at the government. Even some services for like expanded program of immunization, and it is free for non-Omanis also. One of the strong thing which help us in this project is the availability of electronic health system in Oman. So everything is electronic. You can go back to the records 5 years back or more, and you will find all data. We have found that at primary healthcare there are many manuals, SOPs, and which guide the staff for the different program and for different services they are providing. So because we have also our staff, they are not only Omanis, they came from different countries and they came from different medical schools, but all of them, they are using the SOPs and clinical guidelines to deliver the service. What helped in Oman also is that there's a very clear pathway between primary, secondary, secondary and tertiary. For example, pregnant ladies, all pregnant ladies should register at the first 12 weeks at the health center, and which is near to their houses. And then at the first visit after doing the assessment, they will classify that this lady as normal risk pregnancy or high risk pregnancy. Those with high risk pregnancy, we have to refer them to a secondary care where there is a specialist obstetric and gynecologist. She will manage her and make a plan for her, and if everything is okay, she will refer her back to us with a clear plan of how to continue her pregnancy and when to send her back to them. If she needs a further investigation or admission, there's also a clear pathway to send her from secondary to tertiary level. We have found there's no variation or very minimal variation in the primary healthcare system in the different geographical areas in Oman. What helps in Oman also, they have accredited Oman Medical Specialty Board when they train family doctors, graduated doctors, train them and the family and community to become as a specialist in 4 years. And we have also accredited higher nursing diploma for elderly and community nurse. And now we have graduated more than 300 doctors and 250 community nurses. The community nurses, they provide the health services for those people, for those candidates who cannot come to the health center, like bedridden patient or handicapped patient. And we have found that also at primary healthcare, we have extensive continuous staff training, monitoring and evaluation. And I remember the number, it came 300%, and the WHO, they were asking how come you get a 300%? Because simply we told them in each year, each staff, he might go to a minimum of 3 training courses for different programs. So therefore the percentage came as 300%. Next slide, please. Although we are having a lot of strengths, but we have also weaknesses as usual. We have very limited family members. 250 will not cover the whole Sultanate. We have more than 243 primary healthcare institutes, and even we cannot sometimes put one family physician in each health center. We have a staff shortage compared to the service provided by primary health care. And actually, we don't have any separated budget for the primary health care. It is mixed with secondary and tertiary because the classification of the budget is in terms of staffing, drugs, and it is not as per the institute itself. Although we have more than 3,000 approved drug for primary health care, but we still consider this as a short list drug because we provide a lot of services, especially for the chronic diseases. We have all chronic diseases, they are coming to primary health care. If they get complicated, if the disease become uncontrolled, then we have to refer them to secondary. They will see them only for 3 visits and then they will return them back to us. Although we are having many clinical guidelines, but some of them are outdated. Outdated, I mean more than 5 years. So it is the policy here in Oman, we have to update the guidelines every 5 years, but some of them are not. Although we are having appointment system, but it is not very organized system, and people still, they come walk in because, as you know, the service is free. We are having many services and we are having very limited spaces. I mean the building, like for example, we have started in 2016 the physiotherapy for the elderly. We have bought the equipment, but then we could not put all the equipment at the primary health care because of limited spaces. And we have an increased load of non-communicable disease, which all of them, they come to primary health care. Next slide, please. So what is our priority after hearing all this story? If we speak about the weaknesses, it is important for us to increase the number of qualified healthcare professionals, especially doctors, physiotherapists, and community nurses. We have to improve the primary healthcare building space by building add-on. We have to expand our drug list, and we need to have more services with appointment and less weekend or less walk-in. If we speak about priority from the reform and doing things from the beginning, we have to strengthen public health at primary healthcare, because primary healthcare is not only clinical work, and COVID had shown us this very beautifully. It is public health, and we have to strengthen our public health. We have to change the concept of our higher authorities and even to WHO and international study organizations that primary healthcare does not mean simple, does not mean basic, but it's becoming more complicated. We have to work on more preventive services. We have to make the intersectorial collaboration is very structural, although there is intersectorial collaboration in Oman, but it is not very structural. And at the end, it depends on the Ministry of Health staff to move these sectors. If we did not move them, they are not going to initiate a lot of things. If we speak about the priorities based on the measurements gap, we need to introduce new technologies for the diagnostic services like laboratory and imaging services. We have to know separately the budget of primary healthcare, so we know where to allocate our budget more. We have to strengthen our quality management system, auditing system, updating the manuals, and doing extra things on improving quality management. We have to implement an evidence based on the decision maker if they want to start any service or any program, and we have to select some key performance indicator to measure the performance of a primary healthcare level. Next slide, please. So what is our next step? I think Oman need to work more on non-communicable disease risk factor rather than non-communicable disease patient at primary healthcare. We have to work more on making a structural sectorial collaboration, because staff, I mean health professional, they cannot do everything themselves without the other sector help. We have to start more screen cancer, screen a patient on cancers, like common cancers, like we don't have currently screening for the breast cancer or for the colon cancer or for other common cancers. We have to use more telemedicine, because Oman is very wide, and it is not fair for the patient nor for the doctor to bring a patient from very far, almost 1,000 kilometers in very rough road for something which is not important. If there's a telemedicine, we can do counseling over the telemedicine, and we have to, it will be easier whether to shift this patient or to keep him, how to manage him. And as I mentioned, we have to work more on a new technology at the primary health care. Next slide, please.
Dr. Badri,
so,
sorry, before you get into that, we are quite a bit over on time, so maybe we can.
Okay, just take 2 minutes on the COVID.
Sure.
On the COVID, where primary health care has worked on all screening was conducted at primary health care, all contact follow-up, also follow-up of the simple cases. We participated in the surveillance and the outreach and the screening at the airport also. Now when vaccine came, vaccine is done at primary health care. We closed temporarily some routine primary healthcare visit, but as Dr. Hassan has mentioned, essential services has been kept. How this affects us in the primary healthcare measurement indicators, indicator, we did everything by phone. Most of the things, the document was sent by email, and sometimes we are doing virtual meeting. Next slide, please. This is a beautiful, this is a slide how we work and the timeline, and we were able to move into successfully into this timeline. Next slide, please. So in the progression model, we are lucky that two members are worked at primary healthcare, myself and Dr. Ahmed. We work for more than 20 years. We are lucky also because we have electronic government in the country. It is not only Ministry of Health, but we can enter the website, we can get any published data, and we got also a great help from WHO office here in Oman, and from from Emiro office, and Hajar with us, and other staff. They helped us a lot at completing this. And the concerns that we did everything in the COVID period, and sometimes it is not easy to get all the data, and sometimes we need to verify the data. Next slide, please. So this is my final slide, I think. So this is a beautiful slide, how we were able to prove that the majority of the indicators and vital signs are in the green, and only few of them are in the yellow zone, which is very good. Next slide, please. We have got only the red zone is a number of staff, shortage of staff. So I think this is my last slide, and thank you very much.
Thank you so much, Dr. Badria, for your presentation, and congratulations on the excellent work that you and the team have been doing. I'm delighted to introduce Dr. Anis Lakhal next. He is the Director of Hospitals and Ambulatory Care within the Ambulatory Care Division at the Ministry of Health Morocco, and he has also been instrumental in Morocco's participation with PHCMI. I will turn the floor over to him now, and also ask you kindly, Dr. Lakhal, to try to keep your presentation to around 7 minutes.
Thank you. Thank you very much for inviting me to share the Moroccan experience on the primary healthcare measurement and improvement initiative. Let me 1 minute to share my screen. Yes, it's okay for my screen.
Yes, that's working great. Thank you.
Okay, thank you. Thank you very much for inviting me, for sharing our experience, Moroccan experience on primary healthcare measurement initiative. I am very pleased to join this event to discuss the assessment and the improvement of primary healthcare under the PHCMI, and also how to leverage primary healthcare in pandemic response. So I'm Dr. Anis Lakhal from the Ministry of Health, Morocco. I work at the Directorate of Hospitals and Ambulatory Care. So I will begin my presentation by a brief presentation of the Moroccan context. As you know, Morocco is very committed to implement and strengthen primary health care. So since the declaration of Al-Ma'ata in 1978, the Moroccan health system was based on primary health care as the first contact for the population with the healthcare system. And so we have a pyramidal health system with the basic, but also we have hospitals, proximity hospital, regional hospitals, and also university hospitals with a pathway between primary healthcare and hospitals. And also Morocco has adopted the new vision of the Astana Declaration in 2018. And we have a high level engagement and the leadership of His Majesty the King Mohammed VI to reinforce primary healthcare as part of a new reform of health system and also as an essential step toward achieving universal health coverage and sustainable development goals. And also in 2019, after the launch of the PACMI initiative, the Ministry of Health of Morocco were very engaged to implement this initiative because PACMI is for us an important tool that we will use for advocacy to improve primary health care. And also it represents for us an innovative framework to assess primary healthcare system, allowing decision makers and all the partners to identify gaps and also to track progress. So about the PACMI experience funding for our context, I can briefly summarize the process of the implementation of the primary healthcare measurement and improvement initiative. After the launch of this initiative by a regional workshop led by PACMI EMRO team in August 2019, we have set up a steering committee and also a work plan for all of the phases of this initiative. And also we have identified relevant stakeholders and all of the data sources for the 122 indicators for the master indicator list. And then we have collected data since December 2019. And in the early 2020 years, we have delayed our work plan after the pandemic COVID-19 was declared. And so we have proceeded at a readjustment of the work plan linked to this COVID-19 pandemic, March 2020. Then we have worked to synthesize data and doing organized online workshop for the finalization of primary healthcare country profile. And then we finished it by June 2020. After that, we focused our work on the vital signs profile and specifically on the scoring, the internal scoring on the progression model with the implication and the involvement of many stakeholders. So we've done many workshops, online workshops to do and to have a consensus about the internal scoring of the 33 measures of the progression model by July 2020. Then we sent our profiles to the PACPI team for the external validation of the internal scoring of the 33 measures of the progression model with the coordination and the collaboration of the PACMI team in the EMRO. So we have some discrepancies that we have resolved by December 2020. And then the WHO EMRO team has validated our two profiles, PACCP and also the VSP profiles. Then the Ministry of Health, our General Secretary, have endorsed the two profiles by February 2020 officially. So I can brief you about the gaps in measuring primary healthcare key aspects. So this PACMI initiative has allowed us to have some comments about the measure of primary healthcare performance system. Usually we measure inputs, outputs, and impacts of our primary healthcare system, but we don't focus enough on the processes of measurement, which is very important. I can say about the service delivery, we don't measure very well the service delivery and some quality indicators for this process. So it is very important to highlight that PACMI focus our attention on the processes measurement. Also, in some other gap for measuring primary healthcare key aspects, we have the availability of data for some key indicators. Let us speak about the primary healthcare financial indicators. We don't know exactly how do we spend on the primary healthcare from the national budget of Ministry of Health. We have actually the new revision of the social health account, but we don't have enough and precise information about the for the primary health care and the family medicine practice. We must have this approach, and we'll have the availability for some indicator to measure that. So for this moment, we don't have availability of data about person-centered approach, and also about some indicators of about the safety indicators and other quality indicators and so on. Other gaps is in the absence of a comprehensive, performance and computerized routine health information system. We depend repeatedly on surveys. We have to done demographic health surveys, multi-indicators class surveys, and also service availability and readiness assessment and other and so on. So which can be sometimes unavailable or out to date. So for this purpose, we have to reflect on the alternative indicators, or to do continuously or regularly some of these surveys for having the data available and up to date. For the progression model implementation benefits and constraints, for the benefits, there are many benefits. First of all, we have for the first time bringing together multiple stakeholders and partners from the Ministry of Health, other ministerial departments, development, and so on. And also, for the first time, we have evidence-based measure of the primary healthcare capacity pillar, which is the capacity pillar of the vital sign profile of primary healthcare, which the first time we measure exactly the governance inputs and also healthcare facility and management of the population health. Also, for the all stakeholders, is the first time we discuss with multiple stakeholders and they can understand the holistic approach of primary health care, because for the other departments or some NGOs, the primary health care is only the healthcare service delivery at the level of health center, which is wrong. They can discuss with us the progression model, and they know that there is a systemic approach by the input, process, outcomes, and impact. So it's a holistic and systemic approach that was focused on this on this progression model for primary healthcare. And also, for the first time, we have a baseline for all the capacity of primary healthcare system that is evidence informed. So it's the first time that we have this baseline. We have never measured primary healthcare capacity system based on the evidence. So it is a very benefits for us and for the primary healthcare system, and for having this snapshot and this VSP. The improvement strategy also will be directly linked to measurement. This is a very important, because we have many reports about the performance of primary healthcare, but we never use this report to improve, to implement improvement strategies directly. So we have to use the information in the vital sign profile and in the progression model to prioritize relevant areas for improvement. And this is a big advantage really for this initiative. But on the other hand, there are some constraints about the measuring gaps that we have said. That's for the scoring operation, when we have to reach a consensus about the data that are not available or not up to date, it's a little difficult when we don't have the data which are up to date. So it's the first constraint that we have identified in this process. And also the availability of data from the private sector. Effectively, the private sector play a great role in the performance of the primary healthcare system, but we don't collect data from the service delivery of the For the priority areas for improvement phase, we have identified some improvement priorities like the acceleration of the health of information system computerization, which is very important because we have to have precise data in the meantime. We have to reinforce scale up of family medicine. We have to implement family medicine to have person-centered approaches, empowerment of the population. We have to work with the e-family health folders and also training GPs on the bridge program on family medicine. And this is very important to scale up and to perform more our primary healthcare system. We need to invest more in human resources for primary healthcare in terms of availability and also in terms of competency. We have to prioritize primary healthcare for the availability of the human resources because it is the basic of the progress for toward universal health coverage. And also the other areas for improvement phase is to reinforce community engagement and action on social determinants of health, which is very important areas of improvement also because in the pandemic response, we have highlighted the importance of these two components of the primary healthcare system. For the measurement priorities, we have to conceptualize a balanced scorecard for primary healthcare at the regional level. It is very important because primary healthcare measurement initiative allow us to have a snapshot for the national level, but for the regional level also it is very important to adapt these tools to be suitable for the regional level to measure performance also at subnational level. And also we have to advocate for realization of surveys to measure availability, readiness, and also the preparedness of primary healthcare services and system, which is very important when we don't have accurate data. We have to do more surveys regularly to have data precise about the primary healthcare system. And also, we have to integrate quality indicators in routine health information system if we are able to do it. And also to monitor patient experience at the level of primary healthcare, which is a gap that we have identified. Also, we don't measure enough this patient experience on the. Let me talk about the impact of the COVID-19 on primary healthcare. The first one is positive because we have additional financial resources that have been allocated to health sector, including primary healthcare system. So we have the COVID-19 special fund, which allow us to invest more in primary healthcare and also for all the components of the national health system to respond to COVID-19 pandemic, and also other fund from the United Nations COVID-19 Multi-Partner Trust Fund and so on. Also, the impact has the COVID-19 pandemic has impacted the reorganization of primary healthcare network. It is very important that primary health, as Dr. Salah said, maintain the essential health services and also to manage and with the cases of the pandemic or COVID-19 and also to prevent infection. So it is very important for the primary healthcare level to be very strong to contribute to best responsiveness for this pandemic. And also we have strong mobilization of primary healthcare facilities and health workforces for the vaccine rollout. So as you know, Morocco is among the first countries to start rolling out of a national wide free immunization program. And so the primary healthcare facilities and health workforce have a very important role to play in this vaccine rollout campaign. And also about the COVID-19 experience transformation of the primary healthcare measurement and improvement. And it is my last slide. So the COVID-19 pandemic allow us to appreciate and consider more and more the importance of a strong health information system. We need data, we need precise data. So the best way to have data available in precise time is to have a strong computerized health information system. The second one is the necessity to better measuring primary healthcare preparedness and resilience to face current and the future pandemic. This is very important also field that we have to work on. And involve private sector in the measure of primary healthcare performance. As we say that the private sector, we don't have information about service delivery, the accurate data about the number of consultations and so on. So we have to work in cooperation with the private sector to have more data and to assess more effectively primary healthcare system performance. And the other point that I want to discuss that we are working on the development of a new primary healthcare strategies. And this is an area for improvement also. We have to update our primary healthcare strategy. And so in this perspective, a primary healthcare measurement and improvement initiative will be a very important input to identify strategic interventions. So we will use the output of this initiative as an input to conceptualize our new primary healthcare strategy, as well as the recommendations of our National Primary Healthcare Forum that we have organized in December 2019 with the support of WHO and UNICEF. So thank you for your precise attention. Thank you. Back to you, Beth.
Thank you so much, Dr. Lakhal. That was an excellent presentation, and I learned so much about Morocco's experience with the assessment and very exciting things going on in the future. So wanted to turn it over next to Dr. Ghassan Karim, who is the Director General of Primary Healthcare at the Ministry of Health in Libya. Apologize, it's early in the morning here in Washington. Dr. Karim, I hope it would be possible for you to keep your presentation to around 7 minutes because we have another speaker after you. We want to make sure we can get everyone in, and we do have a couple of questions that are coming up in the Q&A on the platform. So I want to make sure we have a little bit of time for discussion before we have to break. And with that, I will hand it over to Dr. Karim.
Hello, thank you so much for giving me this opportunity, and I would like to appreciate all the colleagues here, and also I'm happy to learn from the participants as well. And I'll just open my camera to say hello to everyone, and then I will share with you my screen. I will make my presentation as summarized as possible, but also strict to the point so we can use the time and not to lose our time today. Can you hear me very well, and can you see my screen now?
I can, yes. I think you're fine, Dr. Ghassan.
Okay, please interfere if there was any problem with the connection or the sound or my voice. Thanks so much. So my name is Dr. Ghassan Karim. I'm from Libya. I am the Primary Healthcare Institute Director at the Ministry of Health of Libya, and I'm really happy to join this platform. And I would like to thank WHO, the regional office, and the country office for giving me this opportunity so I can share with you the Libyan experience. And especially, I would like to thank Dr. Hassan Salah from EMRO office and Ms. Elizabeth from the country office for giving me this opportunity. So I will start with the first slide talking just about the levels of care in Libya. We have 3 levels of healthcare: primary, secondary, and tertiary. And this is the number of facilities according to the last assessment. At the primary care level, we have 1,355 facilities. At the secondary level, we have 97 hospitals, and at tertiary care, we have 5 medical centers. I just wanted to say that Libya is a big landmark when it comes to geographical space. And that's why we have this number of facilities, even though the Libyan population is not that big. But the landmark made the need to build more facilities so we can have the transverse distribution of these facilities so to improve the access, and this will contribute, of course, to the universal health coverage. I will go directly to the subject. So the country context. For Libya, you know, I would like to mention in this slide why it was important to work on primary healthcare measurement for improvement and why it was important to work on UHC. So the Libyan context, first of all, if we see the Libyan regulations and rules, the right to health was emphasized in all Libyan laws and regulations, and people, they know that. And that's why we need really to work on this and to provide health as an essential service, but also as a basic right. Then we are in a post-conflict situation. And that's why you can see even from the photos that many health facilities, they were destroyed. Also many health personnel, they were injured, and some of them, they were killed. But also we have a high demand on services, especially for those who have been injured during the conflict, not only the fighters, but also the civilians. And that's why this is an emergency, and that's why it's really important to work on health and to improve health services in Libya because of the need that was created because of the conflict. Then another very important point for the current situation in the country, you know, now we are in transitional state and we are trying to rebuild the peace process. And for peace building, you need to provide essential services. Otherwise, you cannot keep this stability and you will live always in unstable peace. And that's why essential service provision is very important. So people, they can trust the government, and the government, they can trust themselves that they can do better and they can have enough time and resources to work on fixing health system in addition to other sectors. And that's why it's really important to improve primary care and primary health care and primary care services in Libya. Then the fourth and the very important point that is related to the Libyan context, which is the limited resources. I think this is in every country, but especially in Libya, because the conflict has consumed a lot of resources, financial, logistic, human resources, infrastructure, etc. And that's why we need really to be effective and efficient. And here it comes, the role of primary healthcare, because I don't know if there is any other more efficient and effective tool to improve health services and to develop a better health system than primary healthcare approach. And that's why it's really important for the Libyan context and for the Libyan case. Then my second slide is about within all these circumstances and challenges, how we can be more resilient, how we can absorb all these challenges and how we can address all these gaps. So we need to work on implementing this tool and use it for informing the policy makers in Libya. And that's why we start working hand in hand with the WHO country office colleagues, but also with the support from the regional office, in addition to other stakeholders, of course, nationals and internationals. So we started by dedicating someone who should be accountable for following on this as a focal point at the national level, at the Ministry of Health level. And then we use an institutional approach. That means we use the already available institutions and we didn't try to create a parallel system. That means we went through the Health Information Center, through the different departments at the Ministry of Health, through the local authorities, districts of health, through all the facility managers. And we try to engage them through meetings, discussions, workshops, communications. So we will try to use this, and we were trying to use this tool and to use this initiative to support the current system, trying to build the capacity of the system. And that's why we needed to use the available system. I know it was not very effective. I know it was a bit slow, but that was the only way to improve the system, is to go through it, even though this is a very challenging process. Then the assessment, because we needed to reach out not only for those who live in the capital or the big cities, but also for the IDPs, for migrants, for refugees, for all vulnerable groups, that we need to make sure that they have the access to health services, that the coverage is reaching out for them. And that's why the importance of this initiative, it was using a systematic approach. If you go and if you see the tool, and I am sure that many of you went through the tool uses a systematic approach where you can go through every part of the health system building blocks. And then you can go through all the inputs that you need to improve the system. And that's why this tool is very, very nice tool, because it uses this systematic approach. And that's what one of the lessons learned that I will share later, that this tool helped us to use a systematic approach to measure primary health care and also to improve. Then the multi-sectorial approach, it means that we needed to work with other sectors, like for getting the vital signs profile. We needed to work with other sectors like social affairs, the High Authority of Informatics in Libya, Ministry of Labor, Ministry of Interior, other ministries. And also we needed to work with the private sector, with the NGOs. To work on the tool and to collect the needed data, and we needed to engage them in the discussions, and was really important to improve the fragmentation in the country. But even though there was some challenges, one of them was the number of indicators. It was a bit too many for the country capacity to collect data, because it's really good and nice to have the needed information. But sometimes if you have too many indicators, it will be really difficult to collect the data and to analyze all these indicators and to use it to inform the health policies. So this will be one of the recommendations today, is how we can work maybe on classifying the indicators, so we can like keep working on some critical indicators, but also not ignoring other important ones. But we will do that according to the national and local resources and capacities. Then there was another challenge in Libya. I saw from my colleagues in Oman and Morocco, how are the differences between different countries. For instance, in Libya, we didn't have census since long time. That's why to measure many indicators, you need it as a denominator. But because in Libya, because of the conflict, because of the political issues, because of the fragmentation, the fragility, the country has not been able to conduct any recent census. And this will be one of the important achievements that we are working on with other colleagues and other ministers, that we want to do it very soon, because it will be really important for us to implement the tool and to complete the measurement process. And then the fragile context. And this is because of the instability of the Ministry of Health directories, but also the minister and deputy minister in different positions. Because, you know, every a year or every few months, there is a new government, and then a new leaders, and then you need to discuss with them the tool again, and they try to engage them and to show why is this important for them, because the point is not to collect the data and to analyze it, but to use it when it comes to policy making, when it comes to the design of action plans, when it comes to planning process and management process. And that's why this is like, it was one of the very complicated challenges for us. But with the support of the relevant stakeholders, especially our partners, WHO, we managed to go through these challenges very smoothly. Lastly, the pandemic, the COVID pandemic. Even though the tool is supposed to support the local authorities and the national authorities and health facilities to respond to the pandemic, but the pandemic itself, it affected the process of the implementation of the initiative. Because unfortunately, the system was not really able to absorb the pandemic and keep providing the essential services. The system was trying to focus on the pandemic as a priority, and this results in overlooking and neglecting some essential services like services for maternal health or child health and chronic diseases. And we are trying now to work on this with the colleagues on how to keep the essential services at a certain level of quality, but also keep the response to the pandemic. So reflections and next steps. First of all, one of the advantages of this process was to raise the focus on primary care, because it showed how much and how important is the primary care, not only for the health system, but for the national system in general. And then also it contributed to the role of municipalities, because the role of the municipalities has developed during the last years with more decentralization, and such tools, it gives them the ability and the capacity to improve services at the local level, because they need to use such tools for monitoring and evaluation, because their main role is governance, and their main role is to ensure the provision of quality services. And that's why they are really focusing on such tools, and it was really important for us. Then, in Libya, one of the lessons learned was the use of the e-tools. And that's because of the conflict and because of the fragmentation, but also the pandemic. So using the e-learning, the using of the e-communication, like what we are doing now, this platform, using the Zoom platform or other platform, it was really important for us to communicate with local authorities, with facilities, with the health personnel, and also with focal points at the district level to collect the data and to work together on analyzing this data. So even though it was a problem, but it helped the country to develop its capacity when it comes to the use of such electronic tools and the use of social media. And it was also important, as I said, to inform the policies to improve. Because if you cannot measure anything, it's really hard to improve it, and it's really hard to manage it. And we need to work more and to invest more in monitoring and evaluation in such using such tools such as the primary healthcare measurement for improvement. The need to expand participation and engagement, and although many other sectors and stakeholders, they were included in the process, but we still need to include others and to engage them, to communicate to them, and also to explain why is this important for them and why they need to participate with us. And this is the only way how we can address the fragmentation, the current fragmentation in the country. And lastly, the community mobilization. This is important because the communities, people, they have their own authority, and they can influence the political decisions. And if they know how important is this for them, they will increase the demand on primary health care, on improving primary health care. They will increase the demand on transparency and sharing the indicators and sharing these statistics. And that's why it's important now in Libya, this community mobilization which is going on now. And people, they are asking about the performance of the nearby health facilities. And they are asking about the problems within the health sector, and they want to discuss this. So it was really important to mobilize the local communities. And this is not only a pressure on policymakers, but also it's a support to policymakers, so they can work together with the local communities to respond to their local needs. This was my last slide. Thank you so much, and I hope that I didn't use much of your time. Over to you, moderator. Thank you so much.
Thank you so much, Dr. Karim. I wanted to note that that you and Dr. Lakhal both talked a bit about the advocacy power of the data and assessment, and how important it is to arm multiple stakeholders in the community and government and outside government with the information and knowledge they need to hold leaders accountable for improving primary health care. So I thought those are fantastic points among the many other fantastic points you made. So our time is running short, but we do have some additional time, about 7 minutes, just 7 minutes, for our last speaker, Dr. Afzal. Dr. Sabine Afzal is a medical doctor and is currently Deputy Director for Programs and Health Systems, and also Director for Regulations at the Federal Ministry of Health, Federal Ministry of National Health Services in Pakistan. And I'm going to hand it right over to Dr. Afzal to finish up our session today and give the final presentation. We're hoping we have some time for questions, but I'm not sure that we're going to before the session times us out. Dr. Afzal.
Okay, thank you. I hope everyone can hear me.
We can, thank you.
Okay, let's do the screen sharing, and I'll try to be stay within the 7 minutes. So this is the profile. I will not go into detail. The initial UHC index Pakistan was up at 60%, and these were the indicators they were measured. But now with the help tracer indicator, we have improved our UHC indicator to 247. So what Pakistan, as you know, has a devolved setup. So we didn't go to whole of the country. We're giving the 19th amendment to the constitution, and we focused on the Islamabad capital territory so that it can be showcased to the provinces, and then we can further expand it to the provinces. So I will not go into the detail of all the introduction. So this is what the primary health facilities and the focus are. So I'll quickly go through the main things that what was our experience in finding. So the process started into mid 2019, and the data was collected and was presented, and then all the various things was it was reviewed and cleared and everything. 126 indicators were used, and then it went to the EMRO guidance until stage 8. Then it was further validated 2 or 3 times in the ministry, and finally it was resubmitted and approved. Issues that we faced during collection of the data is that the tool was need to be flexible to assess various tiers. It was a very lengthy, there were additional 122 indicators, okay? And they had no linkages, especially with the UHC indicators or IHR indicators. For the people sitting at the PHC, collecting so much data, so much indicators was major issue. And then a country like Pakistan, where is a severe form of devolved setup, collecting a PHC profile where there is a severe variation within the provinces and with the among the provinces, and then within the provinces from district to district. So it was really challenging, and there were major challenges that were, and there were a fear among the people of creating an additional tool of data set with a vertical information system. So these were the major challenges that we faced while collecting the PHCMI data. Eventually, Pakistan was able to develop its vital signs profile, and this is something that we really worked on, and a number of efforts and meetings went into to develop this profile. Okay, but despite of all the challenges, PHC, which need a lot of strengthening in Pakistan, was actually evaluated, and lot of gaps were identified with regards to human resource, infrastructure. Then there was a rural urban PHC system, and how to ring fence the PHC system so that a proper deep well-developed referral system can be developed. Then scaling up of the family practice approach, and then we have a health protection program for those below poverty line, which is currently offering only for the first level care and tertiary care facilities, how to incorporate PHC in the Sehat Sahulat program. So these kind of priority emerges through the PHCMI data. Further developing a patient registry, strengthening referral linkages, updating DHIS to incorporate PHC element, and defining catchment population for health facilities. These were the other priorities that emerged. For the COVID-19, like rest of the world, health system was overwhelmed with the onset of COVID-19 in Pakistan. The government made a very difficult decision of closing outpatient services at secondary and tertiary hospital in the initial phase of the pandemic. And there was a decline in use of provision of essentially health services, including routine immunization, maternal and child health services. The situation was further affected by the complete lockdown in many provinces, and especially in high burden areas, and then also with the smart lockdown as well, and then the poorly functioning primary healthcare system, although further worsened the condition. So this is just a snapshot. How if you can see the bar in yellow and bar in dark in red, these are the one were seen in the COVID, and you can definitely see a decline in reporting of the data and all the usage of all the OPDs during the COVID-19. Number of mitigation measures were taken. temperature screening, encouraging patient to wear a mask, providing hand washing facilities, promote use of digital technologies, filling of the vacant posts, reactivation, media campaigns to encourage people, especially regarding CPR, contraceptive use, birth spacing, guidelines were developed for antenatal care for in wake of COVID-19. And there were a lot of capacity building and delivery in healthcare delivery, newborn vaccination, and gradually we brought the things back to their things to their thing. Let's me go next. Okay. Pakistan is one of the countries which has adopted the DCP3 package and has developed a customized emergency health coverage benefit package. It will help the strengthening to transform the PHC services, especially the package that has been developed for the community and the primary health care. Now we are in a process of getting resources from the government of Pakistan and to pilot it in Islamabad district. This is what the customized package of EPHS at district level look like. We have prioritized about 88 intervention and of which about 37 are of PHC center level, and they will cost around 4.4 USD per person per year and will avert around 21.5% Delhi's. And this is after the implementation of what the health system interventions would be done along with these for strengthening of the PHC MI. And lesson learned in the COVID-19, there is no time for complacency. COVID-19 can give surprises, like it can threaten rise of cases. There is other epidemics or other problems can rise in. They can be late complication. They need to invest more on the evidence generation and using evidence in decision making, ensuring provision of essential health services which are cost effective and target high burden, and the PHC at the community and PHC level, and strengthening of the PHC using the evidence from the PHCMI can be a big good tool to help in developing policies and in evidence making. There can need to be enhanced investment in health and develop a resilient system able to track any health emergency. So I'll stop here and I try to remain within the 7 minutes. Thank you.
Excellent. Thank you so much, Dr. Afzal, and thank you for remaining within the 7 minutes. We're a little bit over time, but I know that it would be nice if folks can stay just a few minutes longer for perhaps one quick question. I know that there are a couple questions that have come up in the portal, and those are being answered, but wanted to see if my colleague, Dr. Hassan, is here and wanted to come in.
Yes.
Very briefly. Oh, there you are.
There is a couple of questions. Let us start with the first question, if we have enough time for the second one. Our question to the panelists: as the vaccine slowly became available, how will be the primary healthcare system in your country contribute to the recovery from the COVID-19? Over to Sabine, Badriya, Anis, or Ghassan, if they can kindly highlight this according to the situation in their own countries.
Can I go first?
Sure, Sabine.
Okay. As you know, you were recently in Pakistan. We are going to implement the UHC benefit package in the primary health care. So that will strengthen the primary health care, and we are focusing on the referral. So what we have added, given the COVID-19 situation, is to develop a sort of a screening points at the primary health care, where people can be screened, and if they have a high temperature or cough or something like that, they can be referred immediately to the from the primary health care to the depending to a center set up at the primary health care, where if the patient only need some advice and can be sent to home, or if they need a referral, they can be sent to the first level or tertiary care or the COVID dedicated hospitals. So this is something that we have done. And another thing that we also developed guideline for the designating hospital as red and green. So those who were COVID, they were red hospitals, and green were those were non-COVID hospital. So PHC can refer patient for essential health care, for routine care, to those green hospital, and this is what the PHC role is envisaged during and hopefully in future, God forbid, we are able to control COVID. Thank you.
Thanks, Rod. Thank you very much, Sabine. Any additional information from Badriya, Anis, or Ghassan?
Can I, Dr. Hassan?
Anis, yes, Dr. Anis, yes, please.
Thank you very much, Dr. Hassan. First of all, I want to mention that in Morocco, we have a very important primary healthcare network distributed all over the country, which is a very good opportunity for the healthcare system, because primary healthcare networks include remote areas. And currently we have about 2,800 primary healthcare facilities, which is an advantage for the prevention and the response to the COVID-19 pandemic. So it's a very important that I want to highlight first. And so to ensure equitable access to COVID-19 vaccines for the population, our strategy for the vaccination campaign is based on the involvement of all the primary healthcare facilities, because these primary healthcare facilities are geographically accessible because they are close to the population, and also financially accessible because COVID-19 vaccination and all other healthcare services provided by primary healthcare facilities are free of charge. And in addition of the vital roles of the primary healthcare facilities to prevent and respond to COVID-19 pandemic, we need also to focus more on maintaining essential health services like NCDs and the communicable disease, maternal and child health, to prevent the increase of morbidity and mortality from causes other than COVID. Thank you. Back to you, Mr.
Can I comment? Can I comment?
Sure, Dr. Badriya, yes, please.
Thank you very much. If we start from the end, the primary health care is not only strong in Oman, but people at the community, they trust primary health care. So for the vaccine, the strategy in Oman is to provide the vaccine COVID at the primary health care because it is near to the people. We at Ministry of Health level, we put the guideline for the criteria for the eligible people, and we receive candidate for the vaccine. The vaccine is for Omanis and non-Omanis. For the COVID pandemic, everything was done. Most of the things was done at the primary health care. Primary health care, they were screening patients at the beginning for symptomatic patient. They were doing the swabbing. We have trained all most of our doctors and even the dentists to do the swabbing. Our primary healthcare staff, they worked at different airports. They screen patients, they do swabbing. We also contact screening. We do contact tracing for the candidate and for the contact also. And we assess the patient by phone consultation. And if those who, and sometimes we'll ask them to come to the health center after the have been tested. We also refer refer them for the hospital if needed. Even admission for moderate cases was done at the primary healthcare hospitals. I mean, local hospitals, wilayat hospitals. Only very sick patient will go to the admission at the critical care or ICU. So we did a lot of surveillance. We did a lot of outreach team at the community, either to screen candidate or to trace the contact or to give the vaccine. And this is what I have tried to explain, that this is it is a new role given to primary health care. The surveillance is a new role given to primary health care staff, and therefore maybe we need to give training more on surveillance, especially in epidemic, in pandemic, or in any other disaster. We have to train our primary health care on the surveillance system more than on the clinical part. Thank you.
Thank you, Dr. Badria. Thank you very much. Beth, over to you, Beth, please.
So we're going to get cut off soon.
No, okay.
So I wanted to actually ask Dr. Hassan if he wanted to wrap us up and close the event. We're a bit over now, but thankfully the platform has allowed us a little bit. Excellent.
Thank you very much. Thanks a lot. As I mentioned actually earlier, I mean, this initiative, it is measurement and then improvement. And we do all this work, which was really tough to get this indicator things and the two profiles. Now we are, as I mentioned, last week we started our first mission to Pakistan, PHC for UHC, and we'll follow with other two countries very soon, to Sudan and Afghanistan. This is great achievement. This is actually, we are going to build on this initiative, very scientific approach, how we are going to go for filling these gaps for the primary health care service delivery. Over to you. Thank you very much. Thanks a lot for this wonderful webinar.
Excellent. And thank you to all of our participants. The presentations were excellent, really interesting. A lot of amazing insights there for this work going forward. And Dr. Hassan and team, we look forward to continuing to work with you.
Thank you very much.
Take care.
Thank you, everyone.
Wonderful
Thank you,
day.
everyone.
Thank you. Bye. Bye-bye.
Bye-bye.